just to highlight a few very interesting things that we see here in our day-to-day in the lab. We now, it's been a little bit over 6 years of, right at 6 years of starting the use routinely of the package of automatic functional imaging, or basically obtaining global longitudinal strain measures on the patients that come requested pre-chemo and follow up during chemo in the lab. So I am going to show this because it's a reference that came out in May last year, so it's very recent and I love it. This group basically examined a very healthy number of patients and tried to, with different equipment, actually quantify both the longitudinal strain measures and also the short axis dimension. So in short axis we get circumferential and radial, and as you can see, I don't know if you can see my my cursor, but you know, here also the implication from base to apex, that there is a rotation, as you can see there on segment 2, in one direction at the base and the opposite direction at the apex, and that's that can be measured. That's basically what we call twist or torsion, and that can be measured in degrees very well, depending on the image. So obviously you would need a short axis at the base and then a short axis at the apex to get that measure. But you know, more traditionally, and this graph is from the ASC consensus statement on mechanical function, we're used to seeing, you know, the longitudinal shortening, the radial as a positive change, and the circumferential as a negative rate change. So this group basically identified a normal longitudinal. When I move the cursor, you guys see it?
Yes, I can see the cursor, Jose.
So then basically here the all patients, and this is 120 healthy normal volunteers, their normal range was 19.6 plus minus 2. So that brings the low limit of normal to a 17.6, and that's basically why I call it normal if the longitudinal value is, in our lab, if it's 18. So I'm rounding to 18 and less. So minus 18, minus 19, minus 20, obviously, then that's what I call normal in the lab. It's a little bit compassionate, I mean, because we know that other groups have called, you know, fixed at 19, and I have to show that inlay because, you know, we have to obviously keep in mind that the mechanical function follows electrical simulation, and as we can see in this graph and from this reference from Dr. Sengupta in 06, we know that the fibers that carry electricity from they travel quicker to the apex than to the base. So there is an advantage in terms of timing for the apex, and it has come into play. I'll show later why I think that's very important. This is the same group from this publication in May that very meticulously looked at all the measures. So they have the circumferential number at normal at minus 28, basically plus minus 4. And this is the first reference to show what the definition of normal was. This came from the group of Tom Marwick, and they define it as minus 18.6 plus minus 1 for the longitudinal value. So basically, that's why they are hard at 19. They basically round to 19. In terms of radial, like I said, it's a positive number. It's a plus 30, plus minus 5. And in rotation, there is a fraction of early on twist. There's twist, and there's a difference in rotation from the base to the apex. So if you in our system, for example, we get the difference from base to apex, and that would be like you see here. That would be a plus 4, and that's why this twist here is defined as 4.1 or so. However, the heart undoubtedly works based on its architecture and given structure, and I want to refer back to this very well-written basic science review by this guy in UCLA, Gerald Buchberg, who very beautifully explained how the heart is a double helix of ascending and descending fibers, and he goes to explaining in detail how the fibers have a clockwise and counterclockwise spirals in there, and it's very well written. I recommend everybody to read this article even more than once. It really changed the way I think, and I didn't read this as a fellow, and I kick myself every day for not reading it, but it's beautiful. It explains how the pattern of a double helix is in everything in nature, including the buds of a daisy flower, and of course if you trace reciprocal spirals, they're everywhere in our digital print, in shells in the ocean, in the form of galaxies, in even our DNA. So it's a very, very neat reference. There is a cardiologist who also talked about this a long time ago, Francisco Torrent Guaspi. He's probably the most famous cardiologist that we've never heard of. He is a Spaniard who dissected in his lab cows' hearts, and he did blunt dissection with his fingers. It just took apart the heart with the tips of his fingers, and showed how beautifully the heart is just what he called a muscular band, and then it's wrapped around and to form the LV, and then a last tongue of that muscle, if you will, is the RV that comes at the end to hug the heart and lays around in this position, obviously. And it's a very nice complement to the reference. There is this movie in YouTube. You can just put it on the search tab, the helical heart, and watch it. It's 11 minutes and 55 seconds long, as you can see here, but it is fantastic. It's one of the best illustrations of cardiac function that I've ever seen in my life, and I very strongly recommend everybody to see it. Here is a part of that movie, and this is a bovine heart passed through a high speed CT, obviously, and it's inflated with air. But when it plays, you get the view of this external and internal reciprocating spiral of the fibers of the heart. It's very neat. This is part of the movie that lasts the 11 minutes. So the power of the heart is really not the shortening of the longitudinal fibers. If that was the case, our ejection fraction could only be at the max 15%, and it certainly isn't the power of shortening or motion in the short axis form, because circumferentially we could only add another 30% of ejection fraction if that was the case. So therefore, potentially the maximum ejection fraction we could ever see is 45%. It's really the spiraling and the fact that fibers are connected all the way through the apex, coiling and coiling all the way to the base, that gives us our normal ejection fraction in the range of 60 and above. It is with strain that we have come to learn this, like, palpably, very clear, at least me in the lab, it really helped me. The one thing that I always reference to is what a normal is. With our package, what we have learned very clearly is that there is a gradient. There is normally a higher level of longitudinal strain in the apex, and it makes sense. The apex is the little tip of the heart, and it squeezes to close. So that and then we have less of the or a lower number in the mid cavity and then the base. That was well seen in the graph that I showed first, with the normal values were defined, where they separated by apex, base, and mid, and you can tell that the apex always in the normal population carries higher numbers. And it's very important to keep in mind in this representation, obviously we know the system is tracking speckles behind this map of dots that separate the base, mid, and apex, and tracks the shortening and makes an average of, let's say, for example, here the anterior septal base from one dot to this dot, from this dot to this dot, from this dot to this dot. The system tracks from the different frame to frame to frame to frame the shortening that is occurring, and if there is a concordance, I believe their secret algorithm is that there's a concordance of 70% or more between them, then you get a reported accepted measure in terms of their own internal quality of 23% average reduction. And it you know, just like I showed, this is the representation of going from 0 at the aortic valve opening, shortening very quickly to the peak. This is obviously a very normal individual. And then in the on-twist, you see the de-lengthening. You see how the represented apex, green and purple, go quickly and go fast back to 0, as opposed to the other segments that lag. So it's very showing a distinct lengthening and unlengthening of the apex separate from the rest of the heart. So it's a very important message to me to see that. Every time I see a normal, I want to see, you know, purple and green here, unlengthening quicker, or I say with more liberty than the rest of the heart. It makes sense because, you know, we see the mid is stuck, the base is really fixed in a certain part, but the apex does have that motion. I have seen now that so well and clear in normal patients that we started to notice in other pathologies how important that gradient is. So, for example, in this case, I know that this is an abnormal one. Obviously, we don't see everything red in this bullseye map, but clearly we see that the apex is sort of preserved. It has very good numbers, and then the rest of the heart falls apart. And you know, obviously I use this to pimp the fellows in a way, because I tell them, you know, I show these maps and I said, what do you think is going on? And basically this is what's going on. And it's timely because actually Cleveland Group just beat me to the punch. They actually published that this is obviously amyloid case, that in amyloid, as different from you know, LVH and hypertrophic IVH from hypertension, and hypertrophs don't have that preservation. They basically would be tan all over, and it's amyloid who accumulates this proteins and this junk that interferes with cardiac function. But there's some apical sparing, and that is very recently been published, I think, in JACC from the Cleveland Group. And then we have the other pathologies where it helps, like this one. And if you know from what I've said and you know where this is going, you could clearly know already by looking at something like this that the next image I'm going to show you, I'm pretty sure some of you already predict that what's coming. This is obviously a an inlay of what an infarct looks like, and for the different territories, LAD, RCA, circumflex, this is where you would see the defects. Here more clearly explained by a reference from the guys, the group of Dr. Cronson. That is actually a very nice review article published in '07 where they looked at strain and the big pattern of an LAD infarct, RCA infarct, and circumflex infarct. So you know that I'm showing you one that doesn't really belong to any distribution. So basically, this is what that is. Obviously, I'm trying to show you a case of typical apical ballooning syndrome, or Takotsubo. And it has helped us differentiate. And actually, we have seen Takotsubo very, unfortunately, we have seen it very frequently here in our inpatient consults. And I'm calling this the evil eye pattern, just like in the Turkish literature. And we actually have a series of these. We have about 40 of them, and we can show that we very commonly can show that the apical wipeout is very clear and distinct, and it leads to early recognition with longitudinal strain imaging. Torsion is obtained by making your system with this type of image, when you get a apical with a base and apical short axis view. The image will look like this, and the system can process it really well. Obviously, very dependent on image quality. If we don't have image quality, and hopefully we have a frame rate higher than this one that I'm showing, we want frame rates in the 60 and above range. But when we have that, it's very easy for the system to come up with the torsion measure, in this case of 3 degrees. So the system is smart. It can do all this for you just by feeding those two images. So cases-wise, I'm going to show you things that I alluded to in the meeting we had here in November, in how I'm using strain in a more day-to-day basis. This is, for example, a patient in my clinic, a 36-year-old female that had metastatic melanoma, and comes from a outside physician. Actually, she was initially diagnosed in 2006, was treated with interferon, IL-2, and a multikinase inhibitor, and in the outside had an ejection fraction of 35-40% at the completion of interferon IL-2 therapy. And at that time, in '06, they actually stopped her chemotherapy because of the change in ejection fraction. They were concerned and scared that she was going to end up having irreversible heart failure. And this lady actually was deprived of further therapy. She ended up coming to MD Anderson in 2010. I saw her in February. They had given her already a second course with a multikinase inhibitor, and on echo, her ejection fraction was 45%, and she was asymptomatic, and they wanted to give her interferon again. Unfortunately, by then, she actually had pretty widespread disease. On echo, this is what we saw. You know, I measured this. I probably have measured this like 70 times, and a few times you get 50. Some of my colleagues were stuck at 45. At that point, however, you know, she was on a small dose of an ACE inhibitor. This one is, for some reason, not playing. The apical 3. But regardless, at that stage of recently received a multikinase inhibitor, ejection fraction by volumetric measures in the 40s. She had a MOGA2, but with strain at that same time, she had a pretty decent value, negative 18.3, And that was enough for me. I actually, knowing this lady was in a big situation with widespread now disease, melanoma spreading to her lungs, you know, and looking at this value, I was very optimistic, and I thought you really can continue with chemo, and indeed they were very aggressive with her, and they gave her again interference. She again received multi-kinase inhibitors, and even IL-2 at one point. Unfortunately, it was too late. She had been told to stop therapy before, and a significant amount of time has passed. So even though that was in November, but this in February, and then in November of 2010, but in April of 2011, more than a year after, her ejection fraction had come up as we expected by having normal strain to the 65 range. But like I said, in her unfortunate case, it didn't matter. She actually died from progressive metastatic disease. And the most common thing in the literature you've seen is how we are using it to then predict dysfunction. And obviously, most of you are familiar with the first time that was published, the group again from Dr. Marwick in 2009, using obviously myocardial deformation. This was longitudinal strain again to predict LVEF drops in the group of patients that were going to be treated with trastuzumab. So again, this was more clearly shown with a larger number of patients. The group of Sher Crosby that we participated on, and the final publication actually came up in Circulation last year. And this is a typical case. This is a lady from my clinic, 63-year-old, has HER2 positive breast cancer and a long-standing history of hypertension with only, when I see her, she's only on 5 milligrams of lisinopril. Kind of so she's not baseline, I didn't think was completely well treated for hypertension, and also 6 months ago had a severe flu, which sort of skewed her history, but she was asymptomatic, had gone through 4 FEC cycles and was about to start Herceptin, and a MAGA here at Anderson had shown her ejection fraction to be 45%. So there were obviously some concerns about what was this 45% ejection fraction coming from, and if it was really the hypertension or not. And we repeated the echo very quickly, and with method of disc volumetrically, we get 45. With 3D, we get 46, and her global strain was also normal at -14. I started her on carvedilol. I have her 3D from, obviously this is a Philips package, but you see her volumes, and we got 46. So it was really believable, and here her strain showing 14, but not only that, showed kind of a defect that was segmental, and I really didn't want to miss anything, so I sent her to the cath lab, and she had non-occlusive disease, systolic dysfunction, most likely secondary hypertension, according to my cath colleagues. But with carvedilol on board, her ejection fraction did improve to 55% by April, and this was confirmed with our 3D. And we started at 14. Sorry. I messed up here. We started at 14 back, and then in June, in the summer, we were lucky to see that she improved all the way to a very normal 19.6, complete red bullseye. But then in more follow-up, this was now, see the screen, this was now then in 2010, in October, she still has some cycles of Herceptin to go, and we saw that that dropped again to 14.6, and now a different segment appear more of a defect of the anterior and lateral. But we know she didn't have coronary disease, so wherever this segment appeared, it didn't really matter. We've seen some data out there with MRI also showing some non-specific defects in the lateral wall, but for whatever that's worth, what this told me is that I was about to see some dysfunction, and it was not typical because, you know, this was already very late on her course of trastuzumab, and indeed, then a few months 2 months later after that, we get an echo. We again, with our biplane, her ejection fraction from 55 is now down to 42. So this is what we see. This is kind of bread and butter use of strain, and I would like to go beyond that to show that, of course, I think of strain as a very powerful measure. It's been shown to be very strong, even for prediction of outcomes on a general population. This again by the group of Marwick, that showed that the GLS was more powerful in terms of predicting death in a 5-year follow-up of almost 400 patients, as opposed to wall motion score index data, which was superior to EF, which was superior to just a baseline score that was composed based of age and the presence or absence of diabetes or hypertension. So that number, as you can see, longitudinal 19, the base 19, the mid 18, but the apex a higher number, just like I alluded before. But so like I showed in the meeting, we know that cardiac mechanics are one thing, and volumetric assessment of the ejection fraction is entirely a different thing. And when they're both are normal, we're obviously happy. When the volumetric assessment is normal and the mechanics are abnormal, we're thinking that it's because dysfunction has started at the cellular level, and the earliest we can see it is with mechanical function analysis. And when both are abnormal, obviously there is something going on, and we stop and think. But we have seen a fair share of people that have an abnormal ejection fraction, but already have normal cardiac mechanics. And I obviously have a lot of thoughts about that could be, and I've been keeping track of these in our case, and we are using it daily to make decisions. So to show you the last two cases, how in a case of pre-stem cell transplant, I saw what happened. 36-year-old man, relapsed Hodgkin's, had a regimen that contained anthracycline in his initial diagnosis in 2007, but unfortunately relapsed in the end of 2010. They wanted to re-give him chemotherapy. The oncologist had known that he had a low ejection fraction by echo from before, but he was seen in our clinic about 4 months after that, sort of in a hurry to proceed with bone marrow transplant. On that same day, I took him very quickly to again measure his ejection fraction on echo, and with biplane method of disc, it was still low. And this is a very athletic, very strong-looking 36-year-old guy with only the one toxic habit of smoking. This is his apical 3, apical 4, and apical 2. 2 weeks later, that was at the beginning of February, on the February the 16th, after starting low dose of beta blocker-kinase inhibitor, this is what we get. Still an ejection fraction of 43, but now the global longitudinal strain looked normal, completely normal. So this was incredible good news. Move forward. Transplant occurred. Follow-up. I'm ashamed to show that they went with Amoga, but clearly showed an ejection fraction in their normal value of 50%, and even later continued on echo to have ejection fractions about 50%. So we're very, very optimistic and happy to see that using strain, despite having a low ejection fraction, was the right thing for that patient. The second case is a patient that I actually saw again just yesterday in clinic. As a young lady who had leukemia and was in an outside hospital, was diagnosed with the APL, and was treated with the 7+3 regimen. Her baseline echoes were only described as visually ejection fraction more than 50%, and 4 weeks later, the echo was abnormal, and two different outside cardiologists had actually told her to discontinue all chemotherapy and basically proceed with a route down the heart transplant consultation. And the patient was completely freaked out and came to MD Anderson. These are echoes, the baseline 50 to 55, the follow-up 40 to 45. She was symptomatic, but it was really only palpitations. This is sort of the opinion that I got from the consuls, would not give another chemotherapy, and it's very distressing to her, and she's engaged, trying to, in fact, even start a family. This is her volumes, 46, with biplane method of discs. But the first day I saw her, I get a longitudinal strain measures on her, and the value comes to be pretty close to normal. I see her again, this is in September, and then I see her again basically a month later, at the end of September to beginning of November. Again, the value looks very optimistic, and so we here actually give her therapy, and these views, I admittedly, are a little bit foreshortened, but her ejection fraction had increased to 52, and I saw her again yesterday, did a quick echo. Again, her ejection fraction is yesterday was right at 50%. Unfortunately, couldn't get strain on her yesterday. She unfortunately had gained quite a bit of weight from the last time we saw her, and could not see the apex well, so tried and tried, couldn't get the artifact to go away, and the strain could not be obtained. So it's a big disappointment for me. But just to emphasize how the most important thing for evaluation really is image quality. So we really depend on image quality to trust the data. And I think that's basically wanted to show, and I thank you for your time and attention. Any questions? I have about 3-4 minutes, and I gotta run.
Does anybody have any questions for Jose?
Can you guys still see my
Jose,
screen?
that was really interesting, I think.
Dan, can you guys still see my screen? Let me show this last case. This is just for fun. 80-year-old female sitting in clinic. She had stage 1 lung cancer. So Vaporcian, you know who that is, Dan, basically cleaned her out. She was a success, a survivor, was basically cured in 2007 with a wedge resection of her lung. But then she followed up at down the street at the Kelsey-Seybold Clinic, where they saw her complaining of dyspnea and palpitations. They don't approve a CT scan here, so they did it over there. And they sent her directly to our cardiology clinic because of a heart abnormality on CT. So this lady is back to MD Anderson, a few years down the road. I'm the first person she sees in MD Anderson for this. I don't have her CT. I have nothing. But I have an echo machine down the hallway. So I take her to see what the heck the CT is. But by the time I'm requesting it, and hopefully by the time I'm done with her in the visit, I have it. And as you can see, 4-chamber, looks like everything is moving. I mean, she's also going tacky at 137, but I don't see any defects on that heart. I mean, I see the apex closing, anterior wall, I see it moving. Inferior wall, I see it moving. Apical 3, anterior septum. This is not playing. Well, that was not playing, but trust me, it was everything moving. And I do strain, and I see this huge lateral defect. And I'm like, wait a second, I just saw the lateral wall moving really well, and how come she has such a humongous defect on the lateral wall? This looks like somebody who just had an infarct on the lateral wall, and the GLS is very abnormal. I bet you that in this CT scan, she has something eating away the lateral wall, and indeed, when I get the CT scan, as you can see here, there is a tumor that you can clearly see how it's even, you can see by the change in color that it's eating away at that base of the lateral wall on this CT slide. So it was kind of fun that you know, that I was able to see that. Anyway, that was the last one. I'm sorry.
That's really cool. So on a routine basis, do you guys do strain imaging?
Yeah. So let me show you then what I did once Juan Carlos left, and I did a minor change here. Let me pull out. They're getting rid of Clinic Station, Dan, by the way.
And what are they going to do with it?
They're buying off-the-shelf product. They gave up on trying to use it for reason, you know, and.
Oh my God.
So, for example, just so that we don't get into any HIPAA violation here, let me let's see, patient list, my patients. Let me pull myself, and now, yes, I go to the melanoma clinic here. Let me beat my own privacy here. And so if you want to order an echo here, we have the cardiology order set, and you guys can see this?
Yes.
And then you go to cardiac care, and there is the echo order. It should be here. So this is the echo ordered. And so we have inpatient, outpatient, and the clinician can order here if they want strain and speckle tracking to the echo with Doppler. However, if you forget to put that there and you happen to just put one of these indications that are in bold, prior to chemo, radiation effects, combined treatment, monitoring during chemo, post-high-risk medications, and echo protocol, any particular protocol, or if you click up here that you know your patient's current chemo include either Herceptin, anthracyclines, or any TKI, by default, automatically, we will do longitudinal measures in the GE. So if you do that, you're going to get a regular echo plus longitudinal measures on the GE. And if you are 16 years old or younger, automatically, by default, we're going to do it on the GE and give you longitudinal strain. We have four GE machines in our lab, 4 IE Philips 33s with the upgrade, but we have had some issues with the reproducibility of the measures on the Philips, so we are using mostly we're sticking to the GE for the strain. I'm sorry to say that.
Well, that's really interesting. I mean, I think that we do strain imaging when specifically requested, but they have too many echoes and they don't have enough echo machines that use that software. So if you anticipate it, you can do it. But if just on a routine patient getting an echo for pre-chemo or whatever,
Yeah.
they're not going to get that type of imaging.
Yeah, I know. When I at the beginning when we started, we were on the learning curve for over a year, and we didn't do it routinely. And yeah, I mean, of the 70 echoes that we do in average, really the average is more like 63, 64. Yesterday probably did 70. Some days we get that high, but probably half of them we do the AFI. And and I can tell you that to be completely honest, not in all of them is also interpretable. Like I said, the biggest killer is the image quality, and the second is conduction abnormalities. I've noticed that even with an incomplete right bundle, even with an incomplete left bundle, we get these defects in the anterior wall, and you have to take it with a grain of salt. You have to know the limitations, and you cannot be very prophetic about it. I have I cannot tell you how many times I have reservations on it as well. So, but it helps that we do it. It helps me that we do it so quote unquote routinely, so that I've gotten to the point that I can recognize the defects a mile away now.
Yeah, but do your techs hate you?
Some of them hate me. But I tell you, when they hate me is when they really hate me is when the patients get done, and it get done on a Philips, and then I realize, oh no, this one needed a contrast, and then we have to do it on the other machine. Then that's asking for trouble. I mean, they want to kill me there.
Yeah, I know you'll have fun with that. Well, thank you so much. Those are really interesting cases. I think we recognize that strain may have some particular advantages, but we haven't figured out how to distribute our resources, to get it done on a routine basis.
Yeah, it also will help if there's a CPT code for it, and Lisa and I started the application. So hopefully, hopefully, MD Anderson is very aggressive at that, at getting paid for the things we do, and so we've had some institutional help offered for that, and hopefully, it can be part of the mix, and then, help it move forward in this day and age.
Well, great. Well, thank you so much.
Jose, I think there's a couple questions there, Jose, from a couple of the audience.
Yeah.
Alessandra, do you have a question? Or Alan Kono?
Good afternoon to everybody.
Hello.
Hello, Daniela is speaking from Milan.
Hi, Daniela.
Hi. Thank you, Joseph, for your great presentation. A general question. Do you think that a reduction in strain rate associated with a normal ejection fraction is an indication for starting ACE inhibitors or beta blockers? What do you do in your clinical practice?
Oh, that's an incredible question, and I love that you asked me that. I obviously, even with normal strain, we have seen that that you just described, that if we're measuring strain and the quality is good, the global longitudinal value is normal, but in those few cases that we have that plus the strain rate, and the strain rate looks abnormal, I'm thinking maybe I'm already predicting with the abnormal strain rate that something bad is coming. And so that is a particular situation that is very concerning. To be quite honest, when I see it, I admit it, I feel a little bit of fear when I see that. And I have heard people discuss that that's the next step. I personally feel that the next step is torsion measuring, but I do have that concern. I don't have any evidence from any trial or any hard publication that I can stand on and say that that's an indication for beta blockers or ACE inhibitors. In my practice, if I meet somebody who has that abnormality, and again, I have to be very convinced of the quality of the imaging to go with that, and they are symptomatic in any way, and I have another reason for it, like let's say they were hypertensive or they are feeling shortness of breath, and what I do is at that time really evaluate them. If I see an echo, in just a regular echo, I try to obtain an ejection fraction with contrast if I can, with 3D if I can, to not miss something. But only if I have another reason to give them beta blocker and ACE inhibitor, I do it. Just alone in a completely asymptomatic patient who just happens to have no abnormal strain rate, I generally don't do it at this time. That's my current opinion. It may change in the future.
Okay, thank you.
And I think Alan Kono has a question, Alan.
Can you hear me at all?
Yes, very well.
Hi, Alan Kono from Dartmouth. Hi, so this is great, but my question is, we also have the ICOS, and we did a study recently that verified fairly good parallel comparisons, but have you been able to use the strain with either vendor interchangeably, or are you kind of pretty much stuck with one vendor for that same patient for a comparison?
Another excellent question. So we tried the CMQ, cardiac mechanic quantification package of Philips, and we actually did that when we were in the middle of the study with Shetter Crosby. We contributed with 17 patients to that study here, and what we did is that on the last follow-up, we would do both. We would do a measure with the GE and another measure with the Philips side by side. And, you know, I have to be honest, unfortunately, we would get about just roughly, this is a very rough estimate, about 50% of the time we would get either a very high number with the Philips compared to the GE or very low, and then we would wait and I would change the sonographer and bring another sonographer to do it again with the Philips, and we would get a totally different number from the first one we already got that was different from the GE. So we kept doing that, and I felt, you know, a loss of faith on that, and then I had some private conversations with, you know, with Plana and Cleveland and even Dr. Marwick himself, and they voiced some issues with their reproducibility with the Philips too, and they have a very good relationship with the engineers, and you know, I think even with the help of the ASC, they got the I think I could be making this up, but I think I heard even they got some sort of FDA permission to both engineers from GE and Philips talk and try to make it be more similar and avoid the you know, the difference that they have. I have slides to show here that, let me see if I find it.
Jose, you had some opportunity to test the SAOTE equipment. Was that compatible, or did you not have enough opportunity?
I did, and I was not impressed. I'm sorry, and I think that I don't know what they are basing the measure from. I think that my question for them is if in the background the information is coming from a Doppler based measure. That's what it seemed to me, and the Doppler. At the beginning, strain was done at a Doppler, and it proved to be too angle dependent to be reproducible and reliable. So that's why this was quickly improved to the use of speckle tracking protocol. So this is a reference in EJE now 3 years ago from Dr. Marwick explaining the differences between the vendors and that there's a different inconsistency. So there has been this big push to make the vendors more consistent. Two vendors mainly, GE and Philips. The GE system, as you can see now on the screen, depends on this map, this horseshoe map, and these tracking of pixels around the area of the dots. The Philips, my next slide, the Philips uses a system called a mesh. And so they have these diamonds or this rhomboids across. And so what they do is that they track at the intersection of the lines, they track these dots, these little dots. And the other thing that I have noticed is on the normals, just like I showed on this first case, when I see a true normal, I have such a good line. They all together, all the segments, traveling together and on lengthening together. In the Philips, I see those lines all over the place, and I just don't. I don't know. Just my gut feeling. I don't like it when I see it. I just feel like I have to look away from the screen.
Yeah, I think we agree.
Dr. Cardinale, have you had any experience with the strain imaging in your institution?
Hi, Dan. No, we don't use routinely strain rate in our institution. So I'm not an expert, and Maurizio Civelli is more expert than me, but we use it only for clinical studies, not routinely. For me, it's too complicated.
Yeah, that's funny you say that, Daniela, because I personally feel like I just, maybe I'm just too compulsive or nerdy about imaging, but to me it helps me because it sort of takes the subjectivity. Even when I do very compulsive volumetric measuring and tracing of the ventricle, when I get an EF, I just feel I don't feel 100% precise. But when I see something relating to the mechanical function, the fiber shortening, and it's the machine with a high frame rate that beats my own eye. Frame rate sometimes of 80 frames per second. That's something phenomenal. It's like a very fancy camera that can see things at a slower motion and track it as a slower motion than I can do with the human eye resolution. So I think it beats me, and that's why I like it. And we say we have the ability, but like I've said here, we if it's requested, we do it. We have the ability. We don't do it on everybody. We just do it when it comes requested, like I showed in the form. But we could potentially do it routinely. We have conquered the learning curve, and all of my 11 ecotechs do it, and they do it very well, and so I'm very happy with that.
I think we're going to take that up with the probably just increase that to the next steps.
I want to thank you, Jose, for doing a wonderful job. That's very complete. We've got a recording of this if anyone wants to to review it. And Jose, that's excellent. We need more exposure to speckle tracking and strain imaging. Dan, we'll just keep your case for the next presentation since we've gone an hour, and I know Jose has to get to the clinic. So thank you so much for your attendance, and thank you so much for your presentation, Jose.
I'm sorry, Dan. To take over and apologize.
No,
Apologize for that.
That was superb, and we look forward to our next meeting, second Thursday of the month next month. Thank you so much, everybody.
all right, thank you.
What a great session.
So did she say it was before or after she took her meds that those pressures were?
Oh, this second clinic speaking, so we couldn't get rid of her.